This panel discussion is on digitising health information to support integration. It's a topic that's quite close to my heart as a commercial lawyer who works with data and digital a lot. And so I was quite keen to chair this one, take the chair's prerogative. And I'm delighted to be joined by our panellists. I'm going to let them introduce themselves, although you don't need to do too much introduction, Guy.
Sorry to be here again.
We'll start with, obviously, you know Guy. Richard.
Hi, I'm Richard Strong from Allscripts. We develop and deliver EPR solutions for acute trusts mainly, and care management solutions across care settings, as well as population health solutions, including we provide the EPRs at the heart of 3 of the trusts within Greater Manchester already. So happy to be here. Thanks for inviting me.
Fabulous. Thanks, Richard. And Sally.
Hi, I'm Sally. I'm from a company called Patients Know Best. So it probably won't surprise you that I am going to be thinking about the role of the citizen or patients involved in integrated care and the partnership that they can bring to the delivery of care. We do a personal health record. So what we're trying to do as a company is get as much data, and you'll see data's been a recurring theme, but we're trying to get as much data in the hands of citizens as possible so that they can be more informed and actually be a conduit in the use of that data in a more informed way.
Thank you, Sally. So what I was quite keen to explore really during this panel is it's a couple of key themes. So first of all, where we are now in terms of digitisation of health and care data, and then looking to what the role of the patient and citizen is in that, and how we can build a greater level of trust as well with our population. And then if we've got time, potentially looking towards the sort of the future and the art of the possible in terms of that much more integration. We've heard it around sort of educational records, housing records, that sort of thing. How do you really make that holistic, integrated piece? So Guy, I'm going to start with you, if that's okay. We've obviously heard a little bit about things like the DM shared care record and other things that have been going on, but I'd just like you to take the opportunity really to tell everybody sort of what's the journey been to now, and where are we at in Greater Manchester in terms of digital health information and how that's integrated.
Okay, great. Broad topic. So where we are, we've over the last the GM Care record has been in existence for about 10 years, but during COVID we really accelerated it. So about 2 years ago, we had about 2/3 of the patient records on the GM Care record. So what that meant is 2/3 of the general practices were feeding data. We've got 540 GP practices across Greater Manchester. We've got 10 acutes. We've got a specialist, with the Christie, and we've got social care. And the acutes were feeding data in it, but they had walls in the data, so the Salford patient clinician could only see the Salford patient. So what we've done over the last 18 months is really accelerate that. So now we've got every, I think apart from one GP practice, feeding data into the integrated care record. We've got all our acute hospitals feeding data into that record. We've got social care partially feeding data into that, and we've got all that data visible at the point of care. So when you're in A&E, you can see that data. When you go to NWAS, you can see that data, North West Ambulance Service. So we've come a huge way. I think one of the key things that's really enabled that is the COPI notice, which is the legal basis for data sharing. So you probably, just get techie for a second. So the way that IG works is that the data legally is owned by the data controller. So in Greater Manchester, the GP is a data controller. So we've got 540 individual data controllers. The acute hospitals and individual data controllers. So one of the things the COPI notice did was, as a result of COPI, there was a legal tell to say thou shall share data, which has been fantastic, and that's really helped us accelerate. The COPI notice ends in March, February this year, which means what do we do at that particular point? So key to all data sharing is, because the techie element's not an issue, the issue is about getting information governance right and the legal basis of sharing data. Interestingly, people and patients expect that we're sharing data, and they're surprised we don't. So one of the key things that we've done is we've set up a secondary uses and oversight committee, which has a representation from every data controller, not all the 540 GPs, but representatives from primary care, from acute care, from social care, plus public and patient representatives. And we are going through a process of deep engagement to ensure that that data is available post the end of the COVID notice, which has been really successful. So net, by the end of February, we should have a single information sharing agreement for both direct care and also for secondary usage. So there's a huge sort of push around that. So a huge amount of work has gone around that. The next real stage is how we provide integration across multi-agency planning. So how do you, for example, create a multi-agency care plan where it started in secondary care and then it's seen in primary care? So that's a big push, and we'll be delivering an integrated heart failure care plan in around March this year. We're also be deploying a patient health record capability across Greater Manchester. We're just working through the best mechanism to do that. Ranging, and I'll just be really frank, right? So if you have diabetes, heart failure, you're on a COVID watch list and you needed a hip operation, in GM you need 4 different apps. Yeah. And the problem with the ecosystem is that we create point solutions that are targeted at part of the pathway or a specific disease. So as an experience perspective, it's a nightmare for individuals to consume. So one of the things that we're working hard with NHSX is there's been a huge acceleration of the NHS app because we've all downloaded the COVID passport. So we all do that. So how do we surf that data from the integrated care record into the NHS app framework? I know Docomo do the same in terms of, the patient knows best do the same in terms of the GP record. So that's a big element. To be honest, parking the technology, the biggest challenge is how you incentivize the consumption of the data. So let's just take the example of heart failure. So if we're going to create an integrated heart failure care plan that enables it to be created in secondary care by the cardiac team, that enables the patient to be able to capture their own symptoms and that to be put into the platform, then for that to be available in primary care, how do you incentivize, for example, just take an example, GPs to consume and look at that information? Yeah. And fundamentally, the big element is that you need to connect both the insight with the action you're trying to drive with the right commission service. So actually people look at that information. So in summary, the tech's the easy bit. Yeah, absolutely. And it goes back to the same point, isn't it? You've got to, one, be solving a problem, but also make it easy for people to use. Absolutely. And coming on that very point, actually, I was going to ask Sally to just comment really from that patient perspective. You mentioned, Guy, about GPs, but actually you're relying as well on people putting that data in. And of course, if you're under a consultant, let's say for something, you might see that consultant every 6 months, but you've got that illness or that need for the entire duration of that 6 months period. So what work are you doing with a PKB in order to really empower patients and citizens to take some charge of their own records?
I think it's really interesting, and this comes back to some of the talks that we heard earlier when we talk about that, the total partnership that you need, where the operational change and the transformation change has to go along with digital, because the platform does everything that it needs to do, but unless you put the educational piece as a wraparound with it, with the clinicians and with the patients, and it's not even motivation, it's just making sure people are aware of what's available to them and why they should be using that, particularly from the patient perspective, you're not going to get that uptake. So whilst on the surface we're a technology company and we go around and sell our technology, the hard thing that we do is actually not selling the technology, it's selling the transformation that needs to go around it, and we actually can't do that. We're just the supplier. It's got to come from what Guy was talking about earlier, where you buy something, but there's that acknowledgement of all the investment that needs to go into the implementation of it. And I think that, again, this was mentioned on the panel before, it's not just the implementation at a service level, i.e. what is the NHS doing, how are we educating our clinicians, our administrative staff, everybody that touches on that pathway, but what are we doing from a citizen perspective to make sure that they are involved in that partnership? And it really is. So I know that Victoria's going to be doing the next panel talking about workforce, and actually the role of workforce, we know that it's not sustainable. The NHS cannot be sustained in the way that it's being delivered right now. There is not enough people to deliver the care that's needed. And this is where it comes back to, there's got to be an expectation set with citizens, with people, that so much of your health outcomes are determined by how you live your life. And there is a responsibility of citizens to do that. Now, I'm not saying that people are not responsible, but they're not educated. And this is where it comes right back to the transformation that we need to do. It's got nothing to do with digital platforms. It's got to do with how we actually build that trust and that relationship with our populations, to bring them on board as part of the journey that we're doing, and make sure that they're informed, that they're educated on why certain things are happening, and they know their levels of responsibility within that journey as well. So I think I've probably gone way off topic there, sorry Charlotte, but there's so much in that we need to do with citizens, and not forget about them when we're talking about integrated care, because they're a key part of delivering that integration.
Absolutely. I think just leading on from that, Richard, I would like to hear your views then on how to date we've built trust with people around health records and digitising health records and who holds their data and all of that sort of thing. What's gone wrong so far, because we know that things have gone wrong, and then what you think that needs to be done better in order to build that trust. As Guy says, people assume that certain information is available, but actually they also assume that certain information is not going to be made available to, in other places. And I think we focus a lot on that in the press and not necessarily on the
Well, yeah, absolutely. I mean, that was where I was going to start, actually. I think we haven't educated, or we have educated, but we've actually educated using gutter press, if you can use that terminology. We've allowed our newspapers and our media and TV as well to do the education about patient data generally. There have been some great pockets of work, and I'm sure some of the stuff Guy's been doing in Greater Manchester and engagement has been really good. In London, the One London programme last year did some, several days of engagement with users, but they're pockets. They're not really properly structured, potentially nationally, delivered education programs. So what we've allowed to happen is we've had two full starts. We've had care.data a few years back, and then we've had the GP data for planning and research in the summer this year, both of which were full starts. Mainstream media got hold of them and kind of blew them out of all proportion. The reality is, if we'd taken a different approach, if we'd done maybe a national mandate, and maybe even a suppression of the press from being able to report it for a while, and let the local health authorities or the ICSs, I guess now, take approaches where it comes from, you are already sharing your data, right? You are expecting us that we're sharing your data. You're expecting when you turn up in A&E that your data from your GP or a visit to a local hospital, the A&E clinicians can see it. Half the population are using fitness trackers and everything else. They're sharing their data already in a big way, much bigger than they could control if they were individually managing opt-in, opt-out. So I think we've got to change the story and come from a real patient approach, engaging with patient stakeholder groups at the local health watch levels, in trust, through GPs, etc., and actually have events coming from that way. And clearly we can't control the press, but trying to make sure that it's all about communication at the end of the day. If we're not communicating effectively, we're never going to be successful with it. Yeah,
and having a more proactive communication plan, as you say, rather than waiting for to explode. It seems to be what's happened. Yeah. Thanks very much, Richard. I'm just going to invite questions from the audience if there are a few. Okay. I don't mind. I'll let you lead with the microphone. Thank you very much.
Thank you. Stuart from Adelphi, a global healthcare company. Just a point, and then it leads into a question. Patients know best, but also their carer knows best. And by carer, I don't mean professional carer. I mean the carer that they hopefully live with. And so it's also taking in what they see as their needs. And allied to that is the very, very silent epidemic of dementia, where you can't necessarily find out what the patient knows or what they want. And I wondered how any of you were taking your services or your expertise into looking at this and helping people with this massive silent epidemic. And also particularly bearing in mind that we have here in Manchester one of the top dementia opinion leaders, Alistair Burns at the University of Manchester, who has done an awful lot of work in terms of what is the right kind of dementia care. So how do your services and how does your policy fit in with that silent epidemic?
Thank you. Does anyone want to pick that?
Well, I'll let Guy speak specifically on dementia in Manchester, but I just want to pick up on the wider point about carers. So we have a joke internally at PKB that we were very nearly named Carers Know Best, because we actually started from the story of our CEO, a gentleman called Mohammed. Mo's a doctor, but he's also a patient with a very rare condition. He's got a 1 in a million condition. And the only reason Mohammed is alive is because of his mum. Because going through his upbringing, Mo's mum had to understand his condition better than the doctors that they saw on a regular basis, because she had to take him to so many different appointments. She had to know when they were contradicting themselves, and that's actually where PKB came from. It was the fact that Mo and his mum had to do all of this, and they didn't have a tool to support them, and they wanted a digital platform that could empower both the patient but also their carers. So actually from the very start of the development of our product, we've always had carer functionality, because we recognise that not everyone will be digitally enabled. They never will be, and we've got a big piece of work to do on digital inclusion, and I think there's a long way to go, but you're never going to get 100% uptake of it, you're not. So you need to look at, okay, for those individuals that we can't get digital enablement for, what are the other ways that we can support them? And carers is such a huge area to do that. So it's important that everything, whether it's a technology platform, whether it's the way we redesign services, it recognises the role of the carer within that. And as you say, that they're normally unpaid it's family members, isn't it? And that's who we really need to be pivoting some of these around to make sure that they're included in the design and the restructure. So dementia is obviously one area of that is really important and a really obvious place where those carers need to be empowered to do some of that. But I think it applies to really any long-term condition. The chances are that you have a carer, formal or informal, that's going to be helping you manage that pathway, and it's important that that's acknowledged throughout. Guy, you can probably speak more of dementia in Manchester specifically.
I can't speak clinically and operationally around dementia. What I can tell you what we're doing digitally around dementia. So we will be releasing a frailty and integrated dementia plan on the GM Care record to enable that information to be surfaced around the needs of people with dementia. So from a digital perspective, we are creating an integrated plan that will be available at every point of care that somebody goes to. The carer thing is really interesting, because there's a real challenge with the NHS app about how you delegate access to your carer elements. We're still need to work through with NHS Acts about how that will occur. In terms of the integrated plan that we're going to create, that will be very much so, as I say, we're working with Dementia United to make sure that scope of the plan is correct. We've done a proof of value project with an app which is targeted at people with dementia, that essentially enables them to record how they're feeling that particular day, and provides them a relatively easy mechanism to record a memory or an event for that particular day. We're going through the research that's underpinned by some academic research that is being currently done by Manchester University to determine whether that actually makes a difference or not. I think it's really interesting around how best to engage from a digital perspective people with different conditions. And I think one of the things that we need to be really good at is the ability to create specific user experiences that are targeted for particular different groups. And at the moment, it's like one experience fits all. So as long as you use the tech and you used to be able to download the app, then you sort of have a reasonable chance. I even struggle, when I go onto the NHS app and then go, how do I actually use my app? How do I then communicate with my heart? And there's loads of different things that are really confusing. So I think the industry's got a long way to play in that space. Long story short, we're doing something specifically with Dementia United to understand how we can provide an integrated plan. That's something very tangible that we're doing, so that'll be available at every particular point in care. I think there's a long way to go to really understand what's required on a disease-specific area to understand what works and what doesn't work. I think we're doing some deep engagement around patient access at the moment. So we're doing user-faced workshops specifically around GP access to look at all the tools, whether it's Ask My GP, EGTERN, EMIS, Footfall, to understand true usability for people that are actually patients and people. And you know, we're going to be hopefully get the results of that in the next few weeks. And some of those results are quite startling in terms of the usability of some of the products, or not. So there's something that we need to do a lot more work on in that sort of space.
Thank you. There's 2 questions at the back, so if we could have those together, if that's all right. Oh, sorry. Go on, Tess.
I've just got a couple of questions, actually. Probably one aimed at Guy and then one at probably Sally and Guy. Sorry, Guy. Anything in Manchester going on about connecting up social care data in terms of that information sharing agreement?
Yeah, absolutely. So in the GM care record, I think we've probably got about 6 or 7 adult social care flowing into the integrated care record at the moment. Some childcare that's going in that by. We're you know, the digital maturity that we showed, that method, we're just hopefully, well, we're putting a bid to NHSX to roll out across social care to get a really good understanding of digital maturity in social care. And we've also just put a bid around completing all the funding for all the data flows for adult and child social care around that. Interestingly, most of the challenges again aren't technical, it's about information governance and bringing the data controllers with you through that sort of process. So we're sort of part way through it, we're not all the way through it yet.
So my next question is actually about data controller. So legal as a GP on data controller. I don't think I'm speaking out of turn, but a lot of us, you know, don't think that's right. So there's models about data controller in common, but I actually want to ask the panel, do you see a future where citizens will actually be data controllers?
My personal view, yeah, absolutely. I know I won't profess to be able to understand the legalities of data ownership and data control, and it's interesting, you know, around the power of data controllers, because you're right, every GP is a data controller. So, you know, for us to do the GM care record, we have to engage with 540 individual GP practices to say, are you prepared to share your data? And you know, everybody wants to do the right thing, but you know, what you fundamentally do is you need to build trust. So whoever owns the data, the fundamental thing is we need to maintain trust with all the clinicians, the operational staff, and more importantly, the people and the public, because it's their data. And that's where care.data and all the other things fell down, because we broke the trust. So maintaining trust is number 1 thing for me, irrespective of who owns the data control.
I think that's a really important point, that you can get yourself tied up in, and quite rightly, all of the legal bits have to be done correctly behind the scenes. But I think that you can, from a public perspective, get quite tied up in all of that. And actually, I think it's more about do members of the public need to be data controllers, or what you mean is, do they need to have, you know, be in control of their data? And that's potentially 2 different things that you might not need to address one to address the other.
Can I just add something though? For me, one of the logical extensions we'll get to in, I don't know, 5 years, 10 years, which for me means that the patient or the citizen has to be the data controller, is that the only way we're truly going to get to the real insights you talked about earlier, and prevention and AI recommending different treatments and things, is when we're combining all of the data that the citizen has, and that includes off your smartwatch, your Fitbit devices, heart monitors, SpO2, you know, finger devices, whatever it might be. Patients doing that in their own home, when they're out in the gym or whatever, they will need to control that data as well. So for me, in the long term, all of it has to be in control of the patient, the citizen.
Yeah, thank you. Sorry, there's a couple of questions at the back.
Thank you. My question is from the viewpoint of a patient, not an NHS official. The principle of a shared patient record is unassailable. It's the gold standard. But practically, when I go to my GP, I can access my patient records through patient access. Go to a hospital, I can't. They don't speak to each other. And I understand also that Epic and Allscripts have different proprietary software, and they don't speak to each other. So how are we going to bridge these divides to really get an accessible, joined up patient record from the perspective of a patient?
I'd like Richard.
Yeah, happy to take that.
You were called out.
And Guy may well have some views on this. I mean, as Guy's already said, the GM care record does have a lot of that data in there. The answer to the question, there is only, in my mind, one answer to that, which is we have to have open standards that everyone signs up to and everyone uses. And I'm proud in Allscripts, we call ourselves the open company. And actually we do integrate with Epic in many places around the world through a variety of different tools already. But it's not just Allscripts and Epic, it's every healthcare solution provider needs to be using the same standards in the same way. And as been said several times this morning already, technology is not the problem, although Henry referred to what iterations of standards and whether they're international and all the rest of it. There's technology things around that, but the barriers are actually human. It's about different organisations with vested interests agreeing to work with each other.
I couldn't reiterate that more. It's not a technology problem. There are improvements, but it is definitely it's a people problem why it's not happening. And I think, again, if we go back to Henry's point around procurement, there are limited ways in which you can control some of the organisations that provide these different systems. There has to be a commitment from them, but actually there's got to be a recognition from the buyer. So there's got to be a recognition in the procurement process that if you want somebody to adhere to these standards, you need to make them do it. You need to make sure that's written into your contracts, because actually there isn't a way that centrally these things can be enforced on a lot of the suppliers, because there is no central contracts anymore. The national programme doesn't exist. There's no way that NHS England can say to suppliers, you have to do X, Y, Z. They do some of it through GPIT Futures now, through GP Connect. There are some elements of control, but that doesn't apply to Epic, Cerner. It doesn't apply to those big organisations. So that has to go back to the procurement process, and people have to be clear in what it is that they want to buy, both from the outcomes that we were talking about earlier, but also from a standard perspective. And the buyers have to enforce that, and they have to be strict with the suppliers to say, we won't buy you unless you do commit to these things. We don't care if it goes against what you want to do from a commercial perspective. It's the only way that the NHS can run in a national capacity is when its suppliers admit that they need to run in a national capacity, and that means playing nice with other people as well. And I think, as Richard said, Allscripts do that really well. We have a fantastic working relationship, so it can happen. It's about companies making that commitment.
So I've got quite a perspective around this, right? So from a secondary care perspective, the data that we can get is relatively logistical. So appointment created, inpatient spell, episode, disease. The heart of the challenge really is not necessarily about the technical interoperability, it's that in the clinical practice, actually, when you're in the electronic patient record, at what point are you going to code that document? Mm-hmm. Now, depending on where you go, which organisation, some people use the electronic patient record literally as a booking system. They're not using it to actually encode clinical outcome. And the other challenge is that clinical coding that says guy's got X, Y, and Z usually happens at the point of discharge by an administration team that goes into the HES. Then it comes back. So, the heart of this is how do we enable clinical coding in real time with the clinician that makes it really usable through great user experience that enables that to be produced. And once that's done, the data can flow. Because why today have we still got discharge summaries in paper going to GP, and we spend a lot of money putting PDF documents around? And the reason why is that data is not coded at source from the organisation. So there's something that around the partnership between the EPR vendor and clinicians, because I've sat on the other side on being an EPR vendor, and the big challenge is clinicians go, it's just too clunky to do. Mm-hmm. And so they revert and go, I'm going to write something on paper, and then get the admin staff to do it. And so there's a big thing I think the industry needs to get hold of, which is how do you drive real, true clinical usability that doesn't make it really painful for clinicians to actually provide clinical coding.
And some of that comes back to what you were, back to what you were saying before as well, isn't it, though, that people stick with what they know, and actually there is an investment that has to be made to do that transformational piece. Sometimes, yes, the software needs improvement, and sometimes there is more that we can do around that, but change is hard. Change is, especially when you're talking about the clinical level, where people don't even have time to think about the change they want to do, never mind embed it. And that comes back to that investment that we were talking about, where you put something in, there's got to be a whole change management support piece that wraps along with it, and there's got to be recognition that it takes time. You can't say we want it tomorrow and it'll happen tomorrow. It's got to be phased, and there's got to be an acknowledgement that that time is needed to deliver that.
I think you described collaboration as a hand-to-hand sport earlier. Some words to that effect, and that it is absolutely that. But just back to your point about cooperating. The one thing Matthew Gould said the best thing he did was to put the copia notice in place, which I would absolutely agree was fantastic. But the co-opetition that went on with suppliers when COVID hit was incredible. I spoke to more people in other companies in the first 6 months of the COVID epidemic talking about how we work together to collaborate than I had done probably in the 10 years before that. And what we've got to do is maintain that collaboration, co-opetition type of approach, in my view.
Thank you. Sorry, we are out of time. We're actually going to move on to your session, but so the next session is going to be looking at some solutions in relation to sort of the resource issue that we've been talking about. So thank you all very, very much. That was a really, really interesting conversation. Obviously, if you're able to hang around for lunch, then if there are any other questions, please do go find these guys and ask them yourselves. Thank you very much.
Thanks.